This is Michael Smith of MedPage Today. I'm here at the ASTRO meeting in Boston talking to Dr. Peter Beitsch of the Medical City Dallas Hospital in Dallas, Texas. Dr. Beitsch is presenting data on local radiation to the breast. Dr. Beitsch, can you explain exactly what you did and what the intervention is, and then tell us what you found?
Yes. We started a registry back in 2002 of a device called a mammocyte balloon catheter. And what it is, it's a balloon that we put into the lumpectomy cavity, and then we run a radiation seed in and out of it. And we treat just the lumpectomy cavity, just the right around, about 1 centimeter around the lumpectomy cavity, twice a day for 5 days. So it's an accelerated, so instead of 6 or 7 weeks of radiation therapy, we do it in a week. And it only treats part of the breast. So the full title is Accelerated Partial Breast Irradiation. So we're treating just part of it in a shortened course. Okay,
this is not a randomized trial, it's a registry. But you compared your results with historical controls with standard radiation therapy. What did you find?
You're right, it's not a randomized trial, which would be obviously a better way to gather the data. But if you look at standard whole breast studies in the past, recurrence rates have been in the range from 1 to 5% at 4 years. And we're right in that. We're at 2.7% at 5 years. So our recurrence rates, which is what everybody's been worried about, just treating part of the breast and not the whole breast. It's a bit of a sea change in breast cancer. Everybody was worried that the recurrence rates would be off the chart. And what we found was, if you look at historical controls for the same sort of patients, early stage breast cancers, they're exactly the same.
I see. Should this be used in any groups of people? You spoke earlier of women for whom the standard therapy is really, really impossible.
Right. These as a group, they're early stage breast cancer patients. We like them to be node negative and less than 3 centimeters. But there's a host of women in America that one, may get a lumpectomy and then don't get the radiation therapy that they need afterwards. That may be up to 25% of lumpectomy patients. And then there's a whole group of women that get a mastectomy because they don't have access to a radiation center or close access. I live in Texas. It's a big state. There are women that live 100 or 200 miles from a radiation center. They can't drive back and forth every day for 6 or 7 weeks. They can't go to that city and stay there for 6 or 7 weeks. They can't afford it. So they're sort of stuck with the decision to, do I adequately treat my breast? And if I'm going to, I have to have a mastectomy. Well, now with 1 week of therapy, most women can come into the radiation center and get 1 week of radiation therapy, and they can afford that and with their life and their children and their family and their job, everything they're juggling, and they don't have to lose their breasts anymore.
I see. This is early days. You've only got a few years of follow-up, 4 years, I think.
Correct.
How much longer before you would recommend this on a wider basis?
Well, we would love to have 10 or 15-year data, but we're gathering it as we go. The registry was designed to pick up really outlying increase of recurrences, which we haven't seen at all. So we offer this as not standard therapy, but with some caveats to women that sort of fit in the American Society of Breast Surgeons criteria or the American Brachytherapy Society criteria, which is 45 to 50-year-old women, less than 3 centimeter tumors, node negative, margin negative, and either non-invasive ductal carcinoma in situ or invasive ductal. We're not sure about lobular yet, but that's a huge portion of the population that has access to what we think is very safe treatment in an accelerated fashion.
Great. Well, thank you very much for your time, Dr. Beitsch.
You bet.
Michael
Thank you.
Smith, MedPage Today.